Welcome to another episode from the Veterinary Research Channel. Today, we're discussing a fascinating study published in Veterinary Surgery that looks at improving accuracy in correcting limb deformities in dogs. Specifically, it compares traditional freehand surgical techniques with the use of three-dimensional printed patient-specific guides for performing radial osteotomies, which are bone cuts. Limb deformities are complex conditions in dogs and can cause significant pain and difficulty if not treated. The radius and ulna bones are the most commonly affected, often due to uneven growth between these paired bones. This can result in significant angulation, rotation, and even joint problems.
Correcting these deformities requires meticulous planning and precise execution in the operating room. Historically, planning has involved methods like the center of rotation of angulation, often using two-dimensional radiography. While computed tomography imaging is also used, current methods still frequently rely on resolving complex three-dimensional structures into two-dimensional images for quantification. Transferring these detailed three-dimensional plans accurately to guide the actual surgery has been a fundamental challenge.
That's where advanced technology comes in. Computer-aided design for three-dimensional planning and printing is already well established in human medicine across various specialties, including orthopedics. It's particularly suited for bone deformity correction because bone is easily segmented from computed tomography data. This technology allows for printing bone models for practice, performing virtual corrections, and creating custom patient-specific guides designed for use during sterile surgery. While some successful clinical outcomes have been reported using these guides in veterinary cases, more robust scientific examination is needed.
Absolutely. This study aimed to rigorously compare the accuracy and reliability of radial osteotomies performed using these three-dimensional patient-specific guides versus a traditional freehand approach. They tested 3 different types of osteotomies, ranging in complexity, on normal ex vivo canine thoracic limbs. Their hypothesis was that using the three-dimensional printed guides would result in more accurate osteotomies, specifically within a clinically relevant threshold of 5 degrees of the intended target, compared to the freehand method in this canine model.
Let's dive into the results. The study found that overall, the mean angle deviation for all osteotomies performed with three-dimensional patient-specific guides was 2.8 degrees plus or minus 2.8 degrees, which was less than the mean deviation for the freehand osteotomies, which was 6.4 degrees plus or minus 6.0 degrees. This suggests the guides generally improved accuracy. Looking at the individual groups, for the simplest type, the uniplanar frontal plane wedge osteotomy, the frontal plane deviation was less when using the guides compared to the freehand approach for both the proximal and distal bone cuts. However, there was no significant difference found in the sagittal plane deviation or the overall three-dimensional angle of the removed wedge for this group.
For the second group, the oblique plane wedge osteotomy, the guides showed improved accuracy specifically for the frontal plane deviation of the distal osteotomy. Again, no significant differences were observed for other osteotomy or wedge measurements in this group between the guided and freehand approaches. This starts to show a bit of nuance, with the benefit being seen in specific aspects depending on the osteotomy type.
The biggest differences were seen in the most complex type of osteotomy tested, the single oblique plane osteotomy. In this group, the freehand osteotomy deviation was significantly greater than the guided approach in both the frontal and sagittal planes. When looking at the combined deviation in 3 dimensions for this complex osteotomy, the freehand group also showed increased deviance compared to the guided group. The researchers established a clinically acceptable threshold of being within 5 degrees of the target angle. Overall, 84% of the osteotomies performed with three-dimensional patient-specific guides were within this 5-degree deviance from the target, compared to only 50% of the freehand osteotomies.
That 84% versus 50% figure really highlights the difference in consistency. Digging into the groups regarding this threshold, in the first group, uniplanar wedge, a substantial 63% of the freehand measurements exceeded the 5-degree target, while only 9% of the guided measurements did. In the second group, oblique wedge, the difference was less pronounced, with 25% of freehand measurements exceeding 5 degrees compared to 19% for the guides. But for the complex single oblique plane osteotomy, Group 3, a full 75% of the freehand measurements were off by more than 5 degrees, whereas only 25% of the guided ones were. This suggests the guides provide a significant advantage in achieving consistently acceptable outcomes, particularly with increasing complexity.
Interestingly, while angle accuracy varied, the osteotomy location was generally quite accurate in all groups. The mean deviation from the target location was less than 3 mm for all 3 osteotomy types and wasn't significantly different between the guided and freehand approaches. This indicates that surgeons could generally place the cut at the right spot regardless of the method.
Time was also evaluated. For the wedge osteotomies in groups 1 and 2, there was no significant difference in the time required to perform the cut using the guides versus the freehand approach. However, for the single oblique plane osteotomy in group 3, the guided approach was significantly faster than the freehand method. The time difference was roughly a minute, which might seem negligible in the overall surgery duration, but it was statistically significant in this study.
Moving into the discussion, the authors reflect on how their hypothesis was partially supported. The guides did improve angle accuracy, particularly for the straightforward frontal plane wedge and most notably for the most complex single oblique plane osteotomy. The finding that angle accuracy wasn't different in the sagittal plane for the wedge groups is interesting, and they speculate this plane might be easier for intraoperative assessment, and saw alignment freehand. The guided osteotomy accuracy was generally consistent across all planes and typically within that desired 5-degree range.
The study acknowledges that factors like surgeon experience could play a role. The osteotomies were performed by a surgical resident under supervision. The resident had limited prior experience with these specific corrective osteotomies, although they did practice beforehand. Additionally, the same individual who did the 3-dimensional virtual planning and guide design also performed the surgeries. This intimate knowledge of the plan likely benefited the freehand group's performance as well. Despite this, the improvement seen in the simpler group's freehand wasn't sustained for the complex single oblique plane osteotomy, which is considered very technically challenging to perform freehand.
Potential reasons for deviation from the planned target were also discussed. For guided cases, errors might arise from slightly imprecise guide placement, the surgeon bending the saw blade away from the guide, or flex in the guide material itself. In freehand cases, inaccuracies could come from technical errors in measurements made on the bone or errors in the angle of the saw blade.
A significant aspect of this study is the novel 3-dimensional methods developed for analyzing the results. They used advanced software to shape-match the postoperative bone scans back onto the preoperative scans. This allowed for a direct and precise comparison of the actual osteotomy plane versus the intended virtual target plane in 3 dimensions. This method is a valuable tool that could potentially be used in clinical cases to objectively assess surgical outcomes.
While the time results from using normal cadavers have limited clinical relevance compared to complex deformed limbs, the authors note that the guides felt easy to apply during the study. Using landmarks like the extensor groove for guide placement instilled confidence, especially in the less experienced surgeon. They subjectively found the freehand osteotomies challenging in the first group, but performance naturally improved with repetition.
The study reinforces that computed tomography-based 3-dimensional planning and printing of patient-specific guides are feasible, efficient, and cost-effective now. Orthopedics, especially complex bone deformities, is a prime area for this technology because of the ease of isolating bone in scans and the technical challenge of these cases. The guides essentially translate a complex 3-dimensional plan into a practical intraoperative tool to ensure accurate execution. They can offer comfort to both novice and experienced surgeons, though they don't replace surgical skill.
The authors share that they have personally experienced a significant shift in their own clinical practices. After performing hundreds of deformity corrections freehand, they have moved to using 3-dimensional printed guides for almost all clinical cases in the past 5 to 10 years. Anecdotally, they report dramatic improvements in ease of application, reduced subjectivity, and shorter surgical times with the guides. While this study used normal limbs as a model, the authors suggest that the difference between guided and freehand approaches would likely be even greater when dealing with actual deformed limbs, where subjective assessment freehand is more challenging.
They only evaluated the accuracy of the osteotomy cut itself in the study and didn't assess the reduction or realignment of the bone segments, which is another crucial part of deformity correction. However, based on their clinical experience, the authors feel that 3-dimensional printed alignment guides, used to reposition the bone after cutting, might provide even greater benefit than the osteotomy guides in achieving optimal outcomes. Their data strongly suggests that as the complexity of the planned osteotomy increases, the use of guides becomes more critical. Ultimately, the guides led to more consistent, acceptable outcomes across all the osteotomy types tested. Future work will investigate the use of these guides in dogs with actual bone deformities to further refine guidelines for when and how to best use them clinically.
Thank you for listening to the Veterinary Research Channel. A link for the reference paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.